I'm Tim Carney. I'm a visiting fellow here at the American Enterprise Institute, as well as being the commentary editor at the Washington Examiner. We're here to talk about healthcare, but I want to ask a specific question about healthcare. And it's a question that some people on the free enterprise side, the free market, conservative or libertarian side, don't always ask. Cui bono, as they put in Latin, or who benefits? And I think sometimes people on the right or right of center are uncomfortable with that question in policy debates because they say, why should it matter who benefits? Because we see, Elizabeth Warren will say a tax cut is bad because rich people benefit. But I think it's actually a very important thing to talk about. One, it definitely influences our debates. If you remember in the 2008 campaign and the passage of Obamacare, Barack Obama certainly thought it was very important to point out that he was battling the healthcare sector, that he was battling the drug makers, or he was battling the insurers. And very importantly and interestingly, he was not telling the truth when he said that. And it shaped the way Obamacare turned out, that the hospitals and drug makers were largely behind it, or that they got to craft certain principles. And it helped us understand why the bill became what it did. It's less surprising that we've seen hospital consolidation when you realize that the big hospitals were supporting lots of the provisions in this bill. So following who benefits from something tells us very important things. Today we're largely going to talk about Medicare for all. And the main way that gets pitched is this is something that will benefit all patients. A common counter-argument is that it will cost taxpayers. I think there's a lot more going on than that, and that's what we will talk about. But not just Medicare for all. Other free market, conservative healthcare reforms, and we've got some people up here who are experts in that, as well as talking about Obamacare and who benefits from all of these. And maybe the answer is simply the patients. But maybe the answer is a special interest. So, and then the corollary, of course, is who suffers from these policies. So we have an excellent panel up here to discuss it. First, Paige Winfield Cunningham is a healthcare reporter who writes a newsletter for the Washington Post, a former colleague of mine from the Washington Examiner. Michael Cannon, and you guys, I think, received their full bios, so I'll just give the brief summary here. Michael Cannon is the healthcare guy at Cato, and Jim Capretta is one of the leading healthcare guys here at AEI. So I'm going to start with Medicare for All and just ask Paige, from what you've seen, from your reporting, from how you see different people playing around this, in various Medicare for All proposals, who do you think benefits, who thinks they're going to benefit, et cetera? What do you see on that?
Well, how much time do we have? Because it could be a really complex proposal, and I think it could play out in a lot of different ways for a lot of different parties. But I think in general, when you look at the consumer, it's going to be lower and middle income consumers that are going to benefit, because what we're talking about is increasing taxes on businesses, on employers, on the wealthy to pay for a more comprehensive set of benefits for the lower income. I think particularly people that could benefit from a more comprehensive Medicare for All plan are the people that have sort of been left behind by Obamacare, which is the people that are, say, around 300, 400% federal poverty level, a little bit higher, who may be eligible for very limited subsidies in the marketplaces, but are
so
still...
sorry, that's like a $60,000 income for a married couple? Or
$60,000 to $75,000 household income for a family of four, I think. And those are folks, I think, that are recognized to really still be struggling to afford their health insurance, and that the Affordable Care Act didn't really help because, of course, the cost of private health coverage keeps going up. The subsidies aren't enough to blunt those costs for these consumers. And then, of course, I guess you could say the losers are, the top 10% or so of income-earning Americans who would have to pay for this. Industry, industry has really come out against Medicare for All. There's this partnership that has been formed where pharma has come together with the hospitals, and the doctors actually were involved in this, and they actually left over the summer, but they've really been fighting these Medicare for All proposals. I think it could be a mixed bag for doctors and hospitals, depending on how this would be hashed out. Because on one hand, they would get more patients because you would reach universal coverage. So they'd have more people seeking their services, but at the same time, they would be paid less, probably closer to Medicare rates, which are significantly lower than what they get under private plans. Drug makers, this probably would be pretty bad for them because the government would have a much stronger role in determining how much they could be paid. And health insurers are also really opposed to this because under Bernie's plan, basically envisions no role for them going forward. So I think that's why you've seen a lot of industry pushback, but I'll leave it there.
So thanks for having me, Tim. And I agree with much of what Paige says. But I think that the population of losers is going to be much broader. And I think it includes a lot of low-income people who might think they would benefit from a Medicare for All program. Certainly, if most of the tax increases are being borne by higher income people and there are subsidies going to people who aren't getting subsidies right now, then those folks might see very little coming out of their pocket and more health care coming their way. They might think that they benefit, but let's also think about some of the ways in which some of the costs that they bear or what they lose. They're losing any ability to choose their own health insurance plan because according to Bernie Sanders, under his plan, the government is going to provide health care to everybody and you have no choice of health insurance plans. We're going to be outlawing private health insurance. So you're losing your right to choose your own health plan. You are also going, people with lower incomes are also going to lose because the impact of the taxes is not only going to be felt by the people who are paying those taxes. And I do believe that in order to pay for Medicare for All system, you would have to tax everybody. You have to raise everyone's taxes. No one's going to be immune to the tax increases. But even if your taxes go up by relatively little, the fact that we would have that Bernie Sanders would have to raise $16 trillion or something in new taxes over 10 years means that the economy is going to take a terrible hit. Collecting $1 in taxes doesn't cost $1. It costs $1.30, or even at the margin, some estimates indicate it costs up to $2. That additional increment is lost economic productivity. So the President's Council of Economic Advisors put out a report where they made some estimates. They estimated that taxes would go up by $18,000 per household under a Medicare for All plan by 2022. $18,000 in additional taxes per household. But the economy would experience so much slower growth as a result of that additional tax burden that household income would be $17,000 lower than it was, or than it would otherwise be without those additional taxes. And even the low-income households would suffer because of that, because there'd be less economic activity, less job creation, less growth. So I don't think you can say that it's just that the low-income people will do well under this under a Medicare for All proposal, because taxes don't just hurt the people who are paying those taxes. Beyond that, I think that patients would also suffer because when you enroll everyone in a Medicare program, you don't get any of the benefits of competition that you get right now and there's not much competition, but there is some competition between different ways of organizing and financing the delivery of healthcare. You do get some competition between totally fee-for-service payment and other payment systems or ways of paying doctors and hospitals. And we do see that fee-for-service has a number of problems. It encourages unnecessary services, unnecessary admissions, and so forth. We do see spillover effects where when there are other payment systems or insurers play a more aggressive role in managing utilization, you do see a reduction in unnecessary expenditures, not only among the patients that those efforts are targeted at, but even among the fee-for-service populations that have to compete with those other ways of paying for healthcare. You get rid of all of that competition and the spillover effects that come from competition, and so patients would suffer. But I think the big winners under a Medicare for All system would be, first, the politicians who get to decide how much we pay in taxes, how much more we pay in taxes, and how to spend all that money of ours. And as a result, the lobbyists who are already, the healthcare has already for the past 20 years led all industries in terms of expenditures on lobbying. And the lobbyists will make an absolute bonanza when we go from the government purchasing 50% of the healthcare in the United States to the government purchasing something much closer to 100%. There are going to be much more opportunities for lobbyists to make money in influencing how that money is spent. And so I think they're going to be the big winners under Medicare for All.
Jim?
Well, thanks, Tim, for having me on the panel. And this doesn't make him change his mind, but I basically agree with everything Michael just said. So I won't repeat all those points. Those were all very good points. I think a couple things to note about Medicare for All. What's the point of the program? The point of the program is to bring the allocation of all the resources in the health system into government control, basically. And so that, it's a tax-financed system. So as Michael indicated, the big loser here really on the first order analysis is anybody who's a wage earner, basically, because the incidence of financing will move more heavily toward income-based taxation of some kind, either a payroll tax or an income tax or some way of taxing the broad middle class. Senator Sanders admits that. And that means you're going to end up taxing wages to some degree more than they're taxed now. So by definition, this is going to be a heavier burden on earned income, which is not necessarily a good thing for the economy for all the reasons Michael just articulated. I think the other point, though, is who's the winner is that people who are going to get health care more, maybe they have very low wages, no wages, they'll end up in a more free direct provision type system. So on a first order analysis, there might be some level of winning for that population, as was indicated previously. But I think the big dynamic here really is something that occurs over 5, 10, and 20 years, which is what happens when the government becomes the controller of all the resources. And almost uniformly throughout the world, when a system is run this way, it leads to price setting by the government, which by definition leads to supply restrictions and less competition. So, sort of basic economics are if the government sets a price below the market clearing level, people will stop supplying it, at least in the same degree they are previously. That's just a reality. And what happens when that occurs? Well, that means that people have to wait longer to get the care that they want. So who loses under that situation? It's basically, and this takes a long time to develop. So you could enact Medicare for All, and this won't be noticed for 15 or 20 years. Mm-hmm. But eventually will happen, and what happens is people wait longer for care, and there's less innovation because you have less incentive to bring forward things that the government is controlling the price for. So who loses under that? It's basically sick people. And so I think here you have to understand that why is there pushback against Medicare for All? It's mainly because people worry about what it would do to the quality of health care over time, particularly for people that need a lot of intensive care and would benefit from innovation, having the best people go into medicine, all the things that happen when it's less controlled by the government and happen to a lesser degree when it is controlled by the government. So, this is the hard reality of Medicare for All, which is one other point about this is very, very important, which is that a lot of the costs of a nationalized government-controlled system are off the books. So the way to measure whether or not something is costing something is usually done in a financial terms. But how do you measure when people have to wait longer or there's no innovation that would have occurred otherwise? Something didn't get made that would have helped the patient if someone had had the incentive to invest in it 15 and 20 years ago. And those are off-the-books costs that occur in the UK and Canada and all the nationalized systems that are not measured. And they're artificially lowering the costs, supposed costs of those systems. They actually cost more because people would pay more if they could get the services faster, but they can't. So there's a whole dynamic here of lost opportunity with Medicare for All that I think is very important to understand.
Can I push back,
Yes,
Bill,
please.
for just to make this point? And this is a point that Senator Sanders often makes in arguing for Medicare for All is, it's really easy to criticize it when you're just looking at the proposal, but you also have to keep in mind what our current healthcare system looks like. And the point he often makes is that people are already paying lots of money out of pocket. You look at employer-sponsored coverage, the average premium now for an employer is $20,000 a year for a family. Costs have been growing faster than inflation for a really long time. And if you look at the Mercatus Center did an analysis of the Medicare for All plan, and even they concluded that there would be a reduction in both national health spending and personal health spending by 2 to 4% if you went to a Medicare for All system. And so part of the point that he often tries to make is, okay, yeah, you're talking about all these costs, but at the end of the day, these services are being paid for by somebody. So what we're really talking about is not necessarily more costs, but just costs that are going to be borne by the government versus directly by the consumers.
Well,
So
but
in
I don't
other
think
words,
that's-
I want to clarify this because for some reason I think Bernie and Hillary and Warren, who both make this argument, never make it very clearly. And you did make it clearly there. But just to reemphasize, if you take taxes paid that go to healthcare and you compare it to the premiums that I pay and the premiums that the Washington Examiner pays, he's saying, well, why do I care whether it's coming out of my wages, coming out of my paycheck, or coming out of my taxes? It's a redistribution, and so the higher wage people will be paying more, and the lower wage people will be getting more health care than they used to. What's wrong with that argument?
Well, you might notice a difference if your taxes go up, but the exact amount your premiums went down. But your brother might not have a job because the economy is not growing the way it would have if you were paying for premiums instead of taxes. But more broadly,
Which brother?
well,
I know which one. I know
multiple.
Which one.
Yeah, and we all know which. We all have that brother. So, more broadly than that, I think it's a mistake to say that the Mercatus study says that under the Sanders proposal, or the Mercatus Center concluded that the Sanders proposal would save money. Because what the Mercatus Center said was, if you take all of the Bernie Sanders plans assumptions at face value and assume that they are plausible, then yes, that is how the numbers work out. But if it is politically infeasible for the Sanders plan that Congress would enact a Medicare for All plan that would reduce prices by the amount that Senator Sanders envisions, then it is not plausible to say that a Medicare for All plan would reduce the prices that healthcare providers get paid, and therefore would be a wash for most people in terms of taxes going up by no more than premiums go down. Their taxes would go up by much more because, and this gets back to something that Jim mentioned. Yes, if the government sets the price too low, then you get shortages and whatever. Everyone always assumes that Medicare sets the prices too low. Medicare often sets the prices too high. The problem with the government prices is not that government set prices is not that they're always too low. It's that they could be too low, they could be too high. The government has no idea and they don't self-correct. They are just as often too high, and that's what all that money, $500 million per year that's being plowed into lobbying on health care in Washington D.C. is going to do. It's being invested in lobbying for usually higher payments to healthcare providers.
This is my question when we say drug makers will probably lose and hospitals are worried they'll lose. And we just think again about how Obamacare happened or about how we generally see the sausage get made here in Washington. I want to tell us a plausible story of how Medicare for All could pass, which is that when we get a Senator Warren and she tries to do this and she fails, but she does what George W. Bush does and has a good midterm, and then she has a bigger Democratic majority, and just like industry reacted in 2008, right after Obama won, the AHIP, the insurance lobby, came out and says, hey, we will cover everybody, all pre-existing conditions, limit our price discrimination based on age, community rating stuff, as long as you cover everybody. They cut a deal. And so you could see the hospitals, the drug makers, the doctors, I don't know about the insurers, but you could see the providers cutting a deal and saying, just give us, make sure you pay us enough, and we'll go along with that. And so then you get a Medicare for all that industry signs up for. Is that a fantasy or is that
so
plausible?
Obamacare happened, and so that lends plausibility to the idea that the same thing could happen with Medicare for all. But it's hard to describe how much heavier a lift Medicare for all would be, because there's no way the insurers get on board with Medicare for all. First off, because
Unless maybe they do a Kamala Harris type of approach.
A Medicare Advantage for all thing
yes.
could work for them, in which case we'd have to buy off the insurance companies, right? And you could buy off all the hospitals and all of that, but you're still talking about removing 175 to 200, well, if you're not Medicare Advantage, 175 million Americans from their private employer-sponsored health plans. And you'd have to put something in there for employers who would be worried about all of the workforce disruption that would come if people didn't have to stay with their jobs anymore. I mean, the number of people you would have to buy off, and that's what you're talking about here. It could happen if government buys off enough people, but that really drives up the cost of a Medicare for all plan.
I think you make a good point about what would the rates be, because that's ultimately what the doctors, hospitals, providers are worried about. The Mercatus Center, I think, assumed a 40% reduction in payments under what they're getting now, which I mean, you're right. Like politically, you would have the industry just completely screaming in the ear of Congress.
None of us would like 40%
that
reduction in the payments for our services.
But this all goes to what is the cost of Medicare for all. And so obviously if you're going to pay hospitals and doctors more, that's going to cost more overall. I think I agree that we're pretty far away from Congress actually being able to pass anything like this. But you can tell that the industry is really worried because, last summer is when they formed this partnership because they saw it being talked about more among the Democrats running for president. And they're really worried that this is kind of where the party's going. And I agree that if Congress were going to do something like this, it would have to involve higher rates to providers. There would have to be some kind of role for health insurers. I don't really know how you get pharma on board, but.
Well, a couple things to say about this. We were talking about winners and losers if Medicare for all got enacted. That's sort of the premise of your initial question. I think maybe one thing to think about is who are the winners and losers from the debate about Medicare for all before it gets enacted, right?
Besides the people on the stage.
Right, besides you having the event. I think, far be it from me to offer advice to the Democratic Party, but I think this is basically a loser for the Democratic Party, really, because they just 10 years ago spent a lot of political capital enacting the Affordable Care Act. And I mean, I maybe have a little amnesia here, but I do remember that President Obama sold it to the country as being a gigantic step toward universal coverage. And if not, the answer to universal coverage. And then now we turn on these Democratic debates and they're spending all this time saying, we've never achieved universal coverage. We got to do this. We have to do some kind of nationalized plan. And there are probably a few Americans out there scratching their heads saying, didn't we already do this? Or weren't we supposed to have already done this? And the answer to that is, we kind of did already do it. And so why are they spending all this enormous political capital saying the government has to take over the whole system when you look at the data and it says, okay, there's 32 million people without insurance in the United States. That seems to be the first order thing they say they want to solve with Medicare for all. But 2/3 of those folks are already covered basically by provisions in the Affordable Care Act. They could get on Medicaid, or they could get in an employer plan, or they could be in the ACA exchanges and be heavily subsidized.
So of those, and this is an important thing. So
there's more to this, though.
Yeah.
Let me finish a couple more points here. That I won't filibuster. Then there's another group out there in the non-expansion states, about 2 to 3 million people who are low income and poor and can't get on Medicaid. So they're a highly sympathetic group. They don't really have a good entry point into some kind of insurance system. And then there are people that have enough income to buy insurance on their own, at least according to the Affordable Care Act structure. And then the last group are the people, the folks who wrote the ACA, including the Obama administration, specifically excluded, which were people who were in the country without proper documentation and couldn't get in subsidized insurance for that reason. It seems to me that it's going to be very difficult to square this circle and sort of say, yeah, now we're going to cover them in a way that the Democratic Party didn't do 10 years ago, And secondly, extend even more subsidies to people that are already being offered subsidies to get into coverage today.
Well, so now we have to turn to the people the rest of the country that's currently insured. So the sales pitch to them is a few parts. One, wouldn't you like to be able to switch jobs or, one of the parents stay at home or something without worrying about losing your health care? This is sort of the pro-enterprise argument to some extent for Medicare for All, is you can go off and start your own small business and you're going to be covered. So there's a lot of people who might have insurance currently through Goldman Sachs, but they want to go and start their own little bank. And if everybody was covered, they could go off and do it. And two, it's just people, have a lot of really difficult dealings with health insurance companies that don't pay, and maybe they believe that the government will be more fair. Now, you might laugh at that second one, but at least address the general idea that people who currently have insurance might think, I would be better off. I'd be more secure, at least. Like, all of us have kids, and we worry, if I lose my job, how am I going to pay my health care bills? To take away that fear might be very valuable to patients.
Well, I think politically that it makes sense that that's what Democrats are speaking to, because a lot of people are discontent with their health insurance and prices are going up. And I think Democrats have successfully also sort of taken over this issue of pre-existing conditions and trying to harness that against Republicans, because as we all know, the Trump administration is refusing to defend the Affordable Care Act in this constitutionality challenge, and we're expecting a ruling on that any day now. But yeah, I think there's still a lot of discontent with health insurance, and the ACA didn't fix a lot of that. And I think Obamacare has been so politicized that people think about it as a lot bigger than it really is. It for the most part only touched on part of the individual market. About 20 million people got coverage under it. But to Jim's point, we already have the mechanisms to insure a lot of these people. The numbers I've seen show about half of the people who are uninsured are eligible to enroll in Medicaid or get into the marketplaces, and they don't for whatever reason. And so then you're talking about a pretty small subset of people left. And this is also the argument that the industry has been making, which is, why are we talking about this huge overhaul when we really should just be focusing on this 10 to 20 million people that we do need to provide coverage for?
I think the main way that a Medicare for All proposal would reduce the problem of job lock is just by tossing people out of their jobs so they're not locked in there anymore, and eliminating jobs that would otherwise be created. You don't have to have the government take over the entire healthcare sector in order to solve the problem of job lock. All you need to do is stop all the other things the government was doing to create the problem of job lock. The reason job lock is a problem is because somewhere along the line, Congress and the IRS made a series of decisions that says if you get insurance through your employer, it's not taxed, but if you take that cash, that $20,000 that Paige is talking about, as cash wages, then it is taxed. And so that creates effectively a huge penalty on anyone who wants to control that enormous chunk of their own income themselves and buy their own health insurance, portable health insurance that stays with them from job to job. So 90% of people with private insurance in the United States have a really awful form of health insurance that disappears when your job disappears. And so it is strange, this dynamic where the government gets involved in the healthcare sector makes this huge problem, and the solution to that problem is always what? More government. Obamacare is another example. You mentioned there's a lot of dissatisfaction within health insurance companies. I share that dissatisfaction. Part of the reason is because most health insurance companies in the United States work for someone other than the consumer, because the money is not coming from the consumer, it's coming from an employer. So they have to make sure the employer is happy more than the consumer is happy. And they don't have a long-term relationship with the enrollee, because they know that enrollee is only going to be with them as long as they're working for the one firm. But also look at the ACA. The ACA was supposed to fill a lot of these gaps in our health insurance market that were created by the same tax exclusion for employer-sponsored insurance. But it has also sown dissatisfaction with insurance companies. There's been research that shows that Obamacare's pre-existing conditions provisions, the supposedly most popular part of Obamacare, themselves are directly making health insurance worse for people with very expensive medical conditions, like multiple sclerosis. Documented in the economics literature, those provisions are making things worse. And by the way, if you ask people whether they support the ACA's pre-existing conditions provisions, they'll, ending discrimination against people with pre-existing conditions, they say yes, 60, 70, 80%. But then if you ask them, what if the coverage was going to get worse for you or your family, support flips to opposition consistently. So these are not actually popular provisions. And what they're doing is they're making people even more dissatisfied with private insurance companies, which you're right, does prepare the ground for a government takeover of the entire thing. But you have to ask the question, if all of these well-intentioned government interventions are actually making us less and less satisfied with health care, is that going to happen with single payer as well?
But here's the thing. I mean, you're not going to have, Republicans didn't have the guts to try to actually do what many would say is real reform of the health insurance system, which is to decouple health insurance from your job. And this has been the system now that we've had for decades and decades, and there's not going to be the political will to do it. Look back in 2017 when Republicans came out with their repeal, replace, big sweeping reform bills. They didn't suggest doing away with that. And so I think that's one of the reasons they've actually fallen down over and over again in trying to come up with a viable replacement, because they haven't been willing to sort of take that. I mean, if you want like a true free market.
Wait a second. There's some history that needs to be explained here.
But my point is, if you want a true free market in healthcare, you're not going to achieve that when you still have this system where the consumer isn't truly shopping for plans because it's all provided through their employer.
Senator McCain ran in 2008 against President Obama, and ran on a platform of providing every household in the country with a $5,000 tax credit toward health insurance that they would lose if they didn't buy health insurance. So it was basically a universal coverage plan, individualized to households. Everybody in the country would have had insurance. It would have made sure everybody was protected financially against any
exclusion.
It had all kinds of provisions. President Obama, then Senator Obama, ran hard against that, and famously purchased $120 million worth of ads in October of 2008, just before the election, attacking Senator McCain for taxing health benefits for the first time in history. Then, a year later, he proposed taxing benefits for the first time in history. So the level of cynicism that you can have about these debates can be quite high. Mine is pretty high. But my point is that the notion that Republicans have never, or there's never been offered a proposal to move in a more market-driven direction. It's just completely wrong.
No, but they lost their nerve after that moment.
Well, but
he lost the election for a lot of reasons.
But they were never serious about it. I'll stick up for Page here. They were never serious about that proposal.
Well, to be fair, that was before my time. I'm too young to have been around in 2008. So.
It was something, he had to have a health care proposal. Tax credit for health insurance is functionally identical to an individual mandate. So you can talk about cynicism on the part of Democrats, but you also have to talk about cynicism on the part of Republicans. They were offering what is essentially an individual mandate. That was John McCain's plan. Now, I also want to be a little...
And it was in Paul Ryan's plan, too. Actually.
Sure. So I want to be a little harsher on Republicans and a little kinder than Page was at the same time.
There will be a rebuttal to you in a minute, but
okay.
I'll let you go.
So Republicans have never invested in health care. It's just not their thing. I have a joke I like to tell. It goes like this. What do Republicans and Christian Scientists have in common? They don't do health care. And it really shows. And so Page is right that they've never invested the sort of money and time and human capital in trying to advance a real free market set of healthcare reforms. However, that doesn't mean they haven't made any progress, or that they haven't made progress on the problem of job lock, which we've been talking about. I'm not a fan of this administration in general, but one thing they did that has made a difference in health policy is they changed the federal government's interpretation of an exemption from federal health insurance regulations, including the ACA, for something called short-term limited duration insurance. They changed that interpretation in a way that basically creates a parallel free market in health insurance that can coexist alongside of the ACA, that can, despite the name, that can provide secure long-term health insurance to people that is portable, that stays with them between when they move from job to job. So that happened because of a few people in the administration who are committed to health care the Republican Party was able to assemble that level of critical mass in order to change a regulatory interpretation of an existing statute. They have not been able to pull that off at a congressional level.
Rebuttal.
Well, first of all, I'm not one to defend the Republican Party, so that is not my portfolio. I'm not interested in doing that. But I think the idea that the reason why more market-driven healthcare hasn't happened and isn't part of our system, although there are elements of it in the United States, it's not really, we wouldn't describe it that way now. Why hasn't that happened? I think the biggest opposition to it is the Democratic Party. The Democratic Party for many years has been incrementally pushing many policies to try to have, and this is, honest, this is just their point of view. They would rather have the government control the resources than having a consumer-driven, market-driven system. And they've been able to sell that point of view probably more successfully to some degree with the public than the opposition has been trying to sell the other point of view. So we've gradually moved toward more and more regulation of the system, more and more subsidization of the system. And I think we're at a point where it's quite true that if we don't want to keep going down that road, there's going to have to be much more aggressive promotion of a real market-driven system.
Isn't the other part of the problem the industry lobbyists? So
but the fact that the Democrats and the left care a lot about health care can't explain why Republicans don't care about it. Okay, look at the health policy landscape across Washington D.C. And across the country. How many foundations are there on the left? They're sitting on huge piles of money. They're dedicated to nothing but influencing health policy. You can think of a few off the top of your head. Name one on the right. Name one that's dedicated to free markets. Think of all the health policy wonks.
Cato Institute.
Think of all the health policy wonks. We don't have an endowment. Think of all the health policy wonks throughout Washington, D.C. How many of them are on the left and how many of them are on the right? On the free market side. There's a huge wonk gap, and I think that it shows up in the sorts of proposals that we see from Republicans. And you're right, it can explain that asymmetry. It can explain why there's been a leftward drift in health policy. But I don't think we can let Republicans off the hook for that just because Democrats care more.
Like I said, I held no portfolio for the Republicans.
And I think that, again, to return to, the swamp factor, right? That industry lobbyists benefit, and the congressional staffers who write the bills, et cetera, then become the industry lobbyists. They benefit the more we have a network of subsidies and regulations. And they become less relevant the more we have guys go at it and compete on your own. And
bringing the two threads together, they also co-opt the free market side. I mean, look at the administration proposal to reduce the prices that Medicare pays for physician-administered drugs. The so-called Part B IPI, International Pricing Index proposal. This is a proposal that would reduce government spending by $8 billion a year, according to ASPE, the Assistant Secretary of Planning and Evaluation at HHS. $8 billion per year in reduced government spending. Yet what's happening? You have conservative groups, I should put conservatives in quotation fingers, taking out full-page ads at Page's publication in the Wall Street Journal, saying this is importing foreign price controls.
And pitching us op-eds on that.
And pitching you op-eds on the idea of it, which is nonsense. Medicare already uses government set prices in order to come up with how much they pay the makers of these drugs. But what's happening is pharma is going to conservative groups and saying, you know what, this is importing foreign price controls. They don't spend much, the conservative groups don't spend much time thinking about these things. So they say, yeah, we hate price controls. Sure, we'll do these ads. And all of a sudden, big pharma has conservative, groups that are supposed to be dedicated to limited government and so forth, advocating for higher government spending in the name of reducing the size of government.
I think Republicans are up against two main things here, and one is that the party is just it's when you're going to be the party of less government spending, when you're talking about an issue that just is expensive, it's going to be a lot harder for you, and just healthcare costs have just skyrocketed in the last few decades with new cures and new medicines and new procedures, and that's great in a way, but coming up with a way to pay for that, and it's really hard to find an example of another developed country where you would have what many would consider a free market system. It's just a really hard thing to figure out. And then health insurance, Healthcare is just a unique kind of good. I like to say that it's the only good that you can purchase when you're unconscious. And so, if you're going to value human life, and we're a country that says we value human life, and so we require emergency rooms to give you care if you walk in their doors, and you may or may not be able to pay for it. But that means that we have a lot of healthcare spending and a lot of healthcare costs, and how are you going to cover that? And I think that's why Democrats are much more readily turn to government solutions. Republicans don't want to, but then that leaves them with this big question of how do we pay for all of this?
To slight correction, I once fell asleep on my couch and pocket bought Taylor Swift's album through my iPhone, so that you can buy when you're unconscious.
Sure.
Yeah, I promise
did.
it was not intentional. I swear. I want to talk. We touch on a couple other policy proposals, and again, an example of why I think it's important to discuss who benefits. Jim, you've talked about surprise billing regulations. One of the counter arguments is if you pass these rules, prices might not come down. And then when we see that the hospitals are lobbying against these regulations, that seems to belie that argument. That's what our colleague Bennett Bolito said. But I mean, so what do you see? What do you see as a virtue of some of the rules that you're talking about on ending surprise billing?
Well, I think on that one, the first thing to understand is it's a real failure of the insurance industry, right? There's nothing out that says that they couldn't be doing whatever they need to do to corral the outlier providers who are doing these surprise bills, mainly anesthesiologists, pathologists, and radiologists. I think the idea, think of it this way. You go in for an elective surgery, you pick your surgeon, you go into a hospital, it's in network, and then they send you a bill saying, oh, by the way, the anesthesiologist was out of network. Why did the insurer let that happen? They could have contracted with the surgeon and said, you can't use an out-of-network anesthesiologist, or the hospital can't use an out-of-network anesthesiologist. But they do allow it to happen because they don't want to deal with the fact that this anesthesiologist has a lot of leverage over them, okay? So I think the first order thing ought to be to push back on the insurers and the hospitals to say, you can't do this. I mean, we shouldn't have to regulate this. It shouldn't be Congress's problem, but because of your failure it is. So you have to, when you say something's in network, make sure that the whole episode is in network. That would get rid of 90% of the problem right there. Now they're saying, oh, well, we can't deal with these poor these anesthesiologists are going to beat us up and they're going to make us, pay them a lot of money. Well, that's your problem. Figure out how to get a lower rate. I mean, that's why we have you. If you can't do that, why do we have you? So I would push back hard on the insurers to say you got to solve this problem. Now, having said all that, I mean, I think Senator Alexander's bill is about as good as you're going to get out of a Congress, right? So don't ask for perfection, and they just say, okay, you got to get corralled. You're going to be inside this, in-network system now, and we're going to back it up by saying you can't charge more than the median rate in a market. I would prefer if they hadn't done that, and if they just had made this fought it out between the insurers and the doctors. But that's the way the political process is, so I can live with that if that's the solution. I think this idea that you need to take all of these things and send them into an arbitration system and have some elaborate way of deciding what the fee is for a $2,000 anesthesiology episode, it's crazy. Why are we doing this at the national level? It's like a huge sledgehammer for a little gnat that should be just killed and gotten rid of. And so I think that shows, this is an indication that when you get Medicare for all, there is going to be a lot of lobbying.
Yeah.
This is a perfect example.
And it'll be a mess.
And so in the latest edition of the Cato Institute's Regulation Magazine, we have dueling articles on surprise medical bills, one by Bennett Bolito from AEI and David Hyman, an adjunct at Cato, arguing for sort of a forced integration model like what Jim was talking about, and then the other article argues for arbitration, I think on the New York model. But when surprise billing comes up as an issue, I always wonder, why aren't insurance companies marketing themselves to consumers on the basis of, if you sign up with us, you will never see a surprise bill? And the answer is, well, manifold. There's the fact that consumers aren't generally purchasing their own health insurance because they don't get to control the money, because if they want to control the money, the government penalizes them. Then there are all the obstacles that the government puts in the way of the sort of integration that Jim and David Hyman and Bennett Bolito are talking about and sort of want to force through through some targeted regulation. There's been 100 years of government interventions that have prevented plans like Kaiser Permanente from forming and spreading and providing a lot of the efficiencies that an integrated and prepaid system like that can offer, including but not limited to reducing the problem of surprise medical bills to zero or almost close or very close to zero. And so I don't have any confidence in either the approach that says Congress is going to solve this problem by setting a price, whether it's something set through an arbitration process or the median in this price in this market, or Congress deciding that we're going to write other terms of exchange between insurance companies and consumers and providers by forcing them to integrate. I think this is a problem that the market developed a solution to more than 70 years ago, and if we just let that process unfold in more areas of the country, reduce the barriers to these sorts of plans, we wouldn't be having this conversation about surprise medical bills in the first place.
I would just add that this is like the prime example of how you take a problem that everybody acknowledges, and everyone even says like the patient should be held harmless. Patients should not have to pay surprise medical bills. And yet it is still devolving into an industry fight. You have the patient advocates in the hospitals on one side who want to do this benchmarking, and then you have the doctors on the other side, and it's just turned in. I actually didn't realize it was going to turn into this much of a fight, and it really has shaped up this way this fall.
Again, good for the lobbyists. They seem to be the consistent winners here. But you mentioned doctors. I want to ask a couple more questions, and then we have mics for a couple more questions, and then we'll take questions from you. Isn't it possible that some of the losers to Medicare for All, for instance, would be industries that are currently collecting rents, that are currently profiting above and beyond what kind of they ought to be, whether you're talking about, social justice or free enterprise? And isn't it very possible that that doctors right now are overpaid, and that if you were putting in place a Medicare for All, there could be a Medicare for All that largely just trims their massive profits, and maybe a fewer mansions in Chevy Chase would sell to doctors in D.C., but they would still keep being doctors and prices would go down because there was a single payer negotiating to a lower price.
So the Medicare Payment Advisory Commission is this commission that advises Congress on how, and the administration, on how and how much Medicare should pay for things. There's this wonderful quote in a report that they issued last year where they said that we have known for some time, we've been aware for some time, that there is a problem, a discrepancy between how much primary care physicians and specialists are paid, about how much Medicare pays them. That is, that primary care physicians are paid too low relative to specialists. Specialists are paid too much relative to primary care physicians. My favorite part of that quote is, we have known for some time. Okay, so they've known about this. They've known that this problem is there, that some people are getting overpaid, and the primary care physicians may be getting overpaid as well. They probably are, if not in terms of P, then in terms of Q, quantity. But this problem has existed for decades, and no one does anything about it. Congress has not done anything about it, and why? It's probably because of the lobbying power of the specialty provider groups. There's another quote in the same MedPAC report where they say, and we're becoming aware that maybe fee-for-service was never a good way to pay for primary care in the first place. Government doesn't learn very quickly, okay? Government makes mistakes, it keeps those mistakes in place, whether they're pricing errors, whether they are errors in how they structure the payments to primary care providers, apart from the price. And so there are overpayments in the Medicare program, and I think that if you move to a Medicare for All system, it's a mistake to think that those payments are going to stay, first of all, as low as they are, that you're going to meet the Bernie Sanders targets, or that that system is going to correct its pricing errors over time. We're just going to end up with the same sort of pricing errors throughout the health sector that we have in the Medicare program right now.
The premise of the question is, that maybe some new negotiator could come in and figure out what the right price is to pay physicians. But I mean, what would they use as a way of figuring that out, right? I mean, it would end up being on an arbitrary basis. in 1989, the Congress created an arbitrary basis for paying physicians under Medicare. It got developed and reformed a couple times since then. But basically, that structure's been in place for all these decades since. That's the reason why. And by the way, when they created it in 1989, they thought they were going to rejigger the formula to reward primary care. So if you go back and look at the studies and the analysis at the time, it said this new system is going to move money out of specialists and into primary care. It's going to be great. And of course, the exact opposite happened. And so this is another one of those things where the government thought they had solved it and they didn't, and they actually made it worse. And so, if the government got involved, and said, we're going to set the prices for everybody, I have no doubt that they could find a price that would be, and I know that they do get things wrong on the upside sometimes, but in this case, they're going to set a low price. They're going to say, we can only afford X because of reconciliation and Congressional Budget Office scoring and whatever else is constraining the system. And they're just going to set a price, and it would lower it quite substantially. But nobody has any idea whether it's the right price.
But I'm not convinced of that.
Sometimes. It's not just sometimes they get the price too high. Look at Part B drugs. They're getting the price too high. The way they pay for Part B drugs is inherently inflationary. Every time you hear about site of service differentials and hospitals buying up physician practices, it's because they know that they get paid more if they provide those services in a hospital than outside a hospital. We're paying too much there. Every time you hear about a physician opening a specialty hospital, it's because they know that Medicare is paying too much for certain patients, and if they start a hospital that caters to those patients, they are going to make a lot of money. I pulled the numbers on Medicare payments for knee replacements, average payments by state. I have the DRG number somewhere. I can get that for you. But the amount that the Surgery Center of Oklahoma charges for a knee replacement, inclusive of the surgeon and anesthesiologist fees, is lower than the price that Medicare pays in lots of states for that same procedure, without counting the Medicare payments for the surgeons and the anesthesiologists. Medicare pays too much in lots of instances, but you never hear it. And this is an example of the effectiveness of the industry's lobbyists. When have you ever heard an industry lobbyist say, no, Medicare's paying us too much. Please stop, lower our payments. They don't say that. So sure, Billy Townsend said it in 2009, 2010, when they said they were going to make an $80 billion contribution to the passage to universal coverage, the passage of the Affordable Care Act. Of course, that was nonsense. If you do the numbers, you see that pharma, he was the head lobbyist for pharma, that pharma was actually making out like bandits. So even when they do say it, it's not true. The government overpays a lot more than people for healthcare, a lot more than people realize.
I think that is a key question that's not debated enough, and that's part of the reason I had this. And we'll see possibly how it plays out as this bill advances. But again, I want questions. We have microphones in the back, so if you raise your hand, a microphone will be brought to you, and identify yourself and ask your question in a question-like format would be appreciated. But the one more question I'm going to ask, because you just mentioned Billy Tozan and Obamacare. Did the drug makers make a mistake in supporting Obamacare? I mean, this is the thing. I write about lobbying all the time, and I say they're supporting this because they're going to get rich, But lobbyists, like government people, don't have perfect vision of the future. Was it a mistake for drug makers and or hospitals to support the passage of Obamacare?
Financially, morally, what are we talking about?
Financially, did their shareholders lose out from that bill passing?
Oh, I don't think so. I mean, you've got how many more insured people as a result of the ACA? 14 million, something like that. People who don't care about the cost of their drugs. Look at the price of hormones and oral contraceptives just happened to shoot up right after the passage of not the passage, but full enactment of the ACA's coverage expansion and contraceptives coverage mandate that requires everyone to buy 100% coverage for those drugs, for oral contraceptives. Even nuns. The prices for those drugs skyrocketed. And I think that drug companies know when they've got a fully insured patient, consumer base, they can get away with higher prices because if an insurance company tries to remove that drug from the formulary, The patients, they don't see any of the savings. It's all downside to them, so they scream bloody murder about that. And the insurance companies are constrained. The drug manufacturers know. So I think, on a very cynical, socially irresponsible financial level, yeah, that was a good move for the pharmaceutical
I like
companies.
libertarians making moral arguments against maximizing profits. That is my favorite kind of
That is
libertarianism.
not, we're talking about plunder here, not profits.
Okay.
Just on the hospital, I don't think it was a mistake for them to support it. I mean, from their perspective, a lot of the rural hospitals have especially been struggling in underinsured areas, and some of those areas are where the insured rate went up right after the ACA, and so they had more patients able to pay for their care.
All right, questions from the audience? Yes, we've got one up front. There's a microphone coming from directly behind you there.
Hi, I'm Bella. Could you speak a little bit to healthcare plans in other developed nations and to universal healthcare plans in other developed nations and how they compare to our current system and a possible Medicare for all system?
Well, most other advanced economies have some kind of system that involves a lot more, well, not a lot more, but put it this way, that the government gets involved to a degree where they control the resource allocation in the system. That's either through a legislative process or a regulatory process or some combination of that. There's a lot of variety in these advanced economies in terms of the health system, so some rely on private, notionally not-for-profit private insurance companies to deliver care, like Switzerland and Germany do. And then some have, direct government provision all the way across the board, such as the UK. And they own the hospitals and they pay the physicians directly through the government. So there's a lot of differentiation across these countries. I think the big point to understand here is something I tried to say at the outset, which is that, what drives a market-driven system is the resource allocation is outside the control of the government to some degree. It's in the hands of people, consumers making decisions, and the people they interact with making decisions about what they're supplying them. And in more nationalized systems, particularly in Western Europe and Canada and in UK and Australia, the government really is the final decision maker on those questions. They set some level of total spending. They say, here's how much we're going to spend on, physician salaries or, services that physicians provide. We set some prices on drugs. So they get very much more involved in the resource allocation decisions. And I think that's, in the end, that's really the crux of the matter, because in those countries, the development of new products, the development of new innovative ways of taking care of patients is diminished to some degree because of that. And moreover, there's a resource allocation misallocation going on that is probably making it harder for particularly very sick patients to get the care they could have gotten otherwise.
Well, so let's walk through sort of the type of patients who benefit in a more socialized system, whether it's England or Canada type system, and the type who lose. So it could be somebody who needs a drug that wouldn't otherwise be invented, would be the clearest example of somebody who would lose in a more socialized system, possibly. But on the other hand, there's the poor person who just needs basic health care, but is just a little bit, who currently benefits from Medicaid or who's just a little bit richer and doesn't. So if you were to walk through different classes of patients, maybe it's older versus younger, maybe it's chronic illness versus acute. What do you see as the winners and losers of different socialized systems versus a more free market system?
To be honest, I haven't studied a lot of other systems that much, but my understanding has been that, I guess the losers in more socialized systems could be, people who are trying to get in to see a doctor or hospital, and there tend to be more problems of physician shortages there, presumably because of lower compensation. I was gonna say earlier, there's been a lot of talk in the Trump administration about the fact that a lot of the funding for new drugs happens in the US because we don't put the same price controls on drugs. And so the administration is actually working on a proposal right now which would peg certain Medicare payments for drugs that are administered directly by doctors to an index of lower prices in other countries. And the idea has been, and the president has talked about this a couple times, that they're basically free riding off of us to where they're relying on us to allow high prices in this country, which fund the R&D for the pharmaceutical makers, and then other companies are benefiting from the development of those drugs while still keeping those price controls so that people aren't paying as much. That's a proposal. Obviously, it's gotten a lot of pushback from pharma, but the latest I've heard is that they're still working on putting out a proposed rule on this.
I think there's a fundamental misunderstanding that guides most of the discussions about international comparisons. And that is that the idea that the United States has a market system and all of these other countries have government-dominated systems. And that's why the United States leads in terms of medical innovations, and other countries aren't pulling their own weight in that regard. I think that that's a mistake, and I think there's another way of looking at this that can explain the phenomena that we see. So the United States doesn't have a free market in healthcare by any stretch. In fact, I like to say that the greatest trick that advocates of socialized medicine ever played was to convince the United States that we don't already have it. Okay? Here we have every form of socialized medicine. You want the British National Health Service? Look at the Veterans Health Administration. You want the Canadian Medicare system? Our Medicaid program looks a lot like that. The German system involves employers a lot. The Swiss system looks like Obamacare. I mean, we've got it all right here.
If you look at melting pot of socialism.
A melting pot of socialized medicine approaches. If you look at who controls the money in the U.S. healthcare sector, about 50% of healthcare spending is done directly by the government. I don't know what's free market about that. When the government takes away, what, $1.5 trillion, $2 trillion from taxpayers and spends that itself on healthcare.
But people don't realize this. You hear people say, get the government out of my Medicare.
Oh, exactly, right, because socialized medicine socializes the cost of ignorance as well. And it's not, it goes even beyond that. If you look at a broader measure of government involvement, which I like to call healthcare spending subject to coercion, we can throw in the 30% or whatever of healthcare spending that is done by employers or pursuant to employer-sponsored insurance. Remember, where the government says either let someone else, your employer, control $20,000, $15,000, $20,000 of your income and pick your health plan, or we'll tax you more. So all of a sudden now the government is directing even more of the market, 80% or more, so we don't have a market system here. I think the U.S. health sector is heavily influenced by government, as the health sectors of any other country, any other advanced nation. But the difference is, and this explains the differences in innovation, is our government make different decisions with the power that it has. No less power than other countries have over healthcare, but it makes different decisions. In the UK, the British government sets a limit on how much it's going to spend on the National Health Service. And then it allocates those resources as best it can, and there's weights and all of that, but they set a limit. The U.S. Medicare program, the U.S. Medicaid program, they don't set any limit on spending in these programs. It's whatever the doctors and the hospitals order up, and the drug companies. In fact, they do. The government does this thing to push prices up, which, so if you have no government limits on quantity, you've got government driving prices skyward with such things as the payment formula for Medicare Part B drugs, or the tax preference for employer-sponsored insurance encourages people to buy more insurance, which encourages them to consume more medical care. You shift the demand curve, price rises. This is what's generating all of the revenue that drug companies are able to make and sink into and the rewards to R&D, and why I think it's an important part of the story for why we have so much more innovation. I don't think, and I think it's a really serious mistake, analytical error, to say that we have more innovation because we have a free market.
All right, other questions? Yes, we've got one microphone right behind you.
Hi, I'm James. So earlier, this panel discussed job locking and employer-sponsored health insurance. My question is, how effectively do health savings accounts reduce the prevalence of job locking? And also, do you think incentivizing employers to provide greater access and opportunity and portability to health savings accounts might further reduce job locking?
You've got a proposal on expanding
So
HSAs.
HSAs as they exist right now don't do much in terms of job lock, because job lock is the idea that you're going to stay in your job because you're afraid of losing your insurance. And HSAs don't do a whole lot to make the insurance more portable. So whether you might have an HSA through an individual market plan, but the HSA doesn't do much to make, and that plan it might be portable, but the HSA doesn't do much to help you afford that plan compared to a world without HSAs. However, if you expand HSAs in the right way, then you can turn them into a vehicle for the worker to receive that $14,000 or $15,000 of their compensation that the employer is using to purchase their health benefits, and to take that compensation without adverse tax consequences. If you expand HSAs in that way, then any employer who wants to stay in business is going to have to give that $14,000 to the worker who earned it, and then she'll be able to buy, well, she could stay in her employer plan if she wants, use that money to pay the premiums for her employer plan. But she could also buy, without penalty, a health insurance plan that does not disappear when her job changes. So I think if you expand health savings accounts in the right way, you can solve that problem of job loss.
So in other words, the employer portion of my premium, I could get them to pay it into my HSA, which now, of course, would exceed the annual contribution limit. But under your idea, boom, I get the $14,000 and I use that to pay premiums on any high deductible plan.
That's
I
right,
want.
and the important thing to understand is that $14,000 is part of your earnings. It's part of your compensation that you don't get to control because of the exclusion, because of the tax preference for employer-sponsored insurance. And if you were able to control that, and workers across the country were able to control that, it would be an effective tax cut on the order of about $828 billion, which is larger than the Trump tax cuts or even the Reagan tax cuts. Because it would be you getting to control part of your earnings that you don't currently get to control.
All right, we have time for one more question, I guess. And if nobody else out there has it, I have it. Okay, we got one red jacket right here. Oh, sorry.
Thanks for taking my question. My name's Ariel Kane, and I work at the Progressive Policy Institute. I just wanted to ask you guys were talking about how Medicare, may be overpaying certain specialties, and how it's a well-known fact. But private insurance, on average, pays 240% of Medicare rates, according to a recent RAND study. And so, if we're worried about Medicare for all costing too much or, overpaying physicians, then how come private insurance isn't doing any better?
Good
question.
It's a great question.
Yeah, I think, first of all, the system we have today is not a market-driven system. So let's agree with Michael on that point, that we only have an hour and 15 minutes here, so this is a very complicated subject. But the idea that what we have in the United States operates with market signals is not true. And so part of the reason why private insurers are overpaying, I agree, I think there's a lot of overpayment in the private side, is because the federal government subsidizes most of that payment. One thing that's been going on from 1945 on, basically, is that on the margin, when an employer plan has higher expenses, the federal government is subsidizing it on the order of about 35% through federal tax break, okay? So when you spend an extra dollar through your employer plan, 35 cents of it is basically coming from general taxpayers, okay? When you have a system built on that kind of a structure, it's going to overpay. And it's going to cost too much because there's not enough discipline, there's not enough money coming directly out of someone's pocket that they don't want coming out of their pocket, okay? If you want a market to work, someone on the margin has to have the decision to say, I'd rather not spend that extra $100 if I don't have to, and I'd rather find another use of getting my service elsewhere for $100 cheaper, okay? Not enough of that is going on in American healthcare to put pressure back on the private side. And it starts a lot with this employer system. So, but beyond that, in the Medicare system, it also operates that way, which is another reason why there's cost inflation, there's too much utilization, et cetera. So when people say they want a market-driven system, which I advocate for very strongly, What it means, in essence, is someone has to pay more out of their own pocket when they buy higher cost health care. If you don't have that, you don't have a market-driven system. And we have it a little bit in the United States, but we don't have nearly enough of it to have a market-driven system. Therefore, the pricing system is all messed up across the board. And people are getting overpaid, there's inflation, there's high prices, there's overutilization, there's waste. There's all kinds of problems in American healthcare because we don't have that kind of a market-driven system. Now, one other point here, though, is that it's not easy to get to a market-driven system. There is one element of this that is hard to get around and has to be addressed, which is that there's a massive information imbalance. And so people basically trust and want to trust and don't want to deal with themselves medical decision-making. So when your physician says, you need to get this done, there are some people, maybe the person to my left, will question it, think about it, look it up on the internet, and try to figure it out on his own. But a lot of people will say, you know, I don't think I can figure this out on my own. I'm going to need to trust someone to navigate me through the medical system. And because of that, the consumer is not quite the same position as they are when they go out to buy a car or even a house or lots of other complicated things. So this trust relationship kind of compromises the market a little bit and has to be addressed in some ways so that the market can function better.
Michael, a last word, and then Paige.
Right
you'll get
now,
the very
as I
last
sit
word.
here, I am currently not undergoing a spinal fusion procedure my orthopedist recommended for me. Okay? You asked, why are prices so much higher in for private insurance than for Medicare or Medicaid? If all we had were a tax preference for health care, we would expect that to, as they say, shift the demand curve and prices to rise. If all we had were if we had on top of that a tax preference for health insurance, we would expect that to shift the demand curve a little more, prices to rise a little more. On top of that, though, we have a tax preference for health insurance purchased by an employer with money we never see, so we're even more insulated from the cost. We would expect that to shift the demand curve even more, prices rise even more. Add to that the Medicare and Medicaid programs. They have an effect on private prices as well. It's not the cost-shifting effect that everyone seems to think it has, which is that, well, Medicare pays below market rate, so providers have to make it up by charging private insurers more. That hypothesis suggests that if you reduce Medicare and Medicaid rates, then providers will charge private payers even more. Actually, the literature suggests that the more Medicare and Medicaid pay, the higher the private prices go, which is actually very consistent. So the very high prices that we're seeing private insurers pay are actually very consistent with my hypothesis that that Medicare is often overpaying rather than underpaying.
Paige, last word.
Yeah, I would just add that, insurers loved the Affordable Care Act because to them it was like the perfect solution. Basically, it was the government saying, we're going to give you money to cover all of these people and we're going to require them to buy health coverage. And I just think, you're going to continue to have this system that we're talking about, all of these issues with private coverage. The employer system is so entrenched, and I don't see a lot of movement by Republicans or Democrats to kind of want to move away from that. In fact, when you look at the Democratic candidates, they came out of the gate, rah, Medicare for all, we've all signed on to Bernie's bill, and you've actually seen a lot of them since back away from that and say, well, we think there should be a role for private coverage. We don't really want to take people's employer-sponsored coverage away from them because I think consumers have a really weird relationship with their private coverage. They say on one hand, premiums are going up, way too expensive, we don't like it, but we also don't want the whole system to be upended. And so Democrats have seen this as really politically difficult position. So you've seen Senator Kamala Harris suggest this idea of private plans continuing to be able to offer Medicare plans. You've seen Pete Buttigieg, suggest Medicare for all who want it. So, people should have the option of staying employer-sponsored coverage or buying into Medicare. I think they made really good points about the cost of private coverage. But I don't really see, the system ultimately changing in really significant ways, probably at least in the next couple of years.
Thank you, Paige. Thank you, Michael. Thank you, Jim. Thank all of you for coming.
Thanks.